Hello, this is Neil Sharma. I'm presenting on behalf of Group D5 for Geriatrics Week 2020. COVID-19 is a deadly disease that disproportionately harms older adults and communities of color. As a result of COVID, many facilities have blocked visitor access in order to prevent the spread of COVID. However, this social isolation has greatly harmed older adults and resulted in significant morbidity. Testing is helpful, but tests are in short supply, and they're particularly burdensome for those in marginalized groups. We often see low-risk visitors who almost certainly do not have COVID-19 being barred from entering facilities, but at the same time seeing people who potentially do have COVID being mistakenly allowed in. We view risk backwards. If a school is open, it doesn't mean that it's safe to go to the movies too. Increased risk in one area must be counteracted by reducing risk elsewhere. Our project aims to maximize in-person interaction between visitors and residents while minimizing exposure of everyone to COVID-19. Low-risk visitors should not go through unnecessary barriers to visit loved ones, and high-risk visitors should be identified. Our proposed intervention is to create a simple, adaptable tool to risk stratify visitors. This tool can be presented as an app or as a worksheet. The app would reduce the need for paper and fomite transmission. As a worksheet, though, it would be effective in low resource settings where maybe everyone can't afford a smartphone. Any staff member would be able to administer the worksheet on behalf of a visitor, but visitors would also be able to do a work on their own via the app to reduce the need for staff attention. But the ultimate goal is to risk stratify visitors before they enter into the facility. So our tool is essentially based on the mini mental status exam, in that we assign points based on how much risk your actions carry. If they are relatively high, then we would require you to have a negative test before entering the facility. But if you have a very low risk, which corresponds to a low score, we wouldn't require testing before you enter the facility. And these risk kind of points are assigned based on a variety of factors, including the local county transmission rate. If you live in an area such as New Zealand where there's very low transmission rates, then you would have very few points because it's unlikely that you would carry a disease that very few people in your area have. But if you live in an area where there's many people who have the illness, then you're more likely to have it. Similarly, depending on your personal behaviors, such as wearing a mask outdoors, where your work environment is, whether it's you spend most of your time working from home or if you spend most of the time working in a high-risk healthcare setting, we would assign different scores based on that. But overall, looking at these different factors will help contribute to whether you're a high-risk or low-risk candidate. The idea here is based on a Bayesian probability model, in that we want to find a pre-test probability that you would have COVID-19 before administering the test. And we would only use the test if you were at a high risk or a higher risk in terms of having this. If you're at a relatively low risk, then we would potentially not need to give you this test. The benefits is that it's adaptable to local resources. It adapts to changes in testing availability, the creation of new vaccines and test kits in the future, the overall risk in a given location, and new evidence related to transmissibility. For example, if a new vaccine is created that offers 50% protection, then we would be able to use that to reduce your risk score. Versus if it provided 100% prevention, then we would be able to reduce your risk score even more. It's a cheap, fast, and simple exam that healthcare providers are used to providing. It's just a simple point system. The barriers to our project being implemented, though, are that we need to have greater public health studies relating to tests, vaccines, transmissibility, before we're able to make this model more robust. My example would be condom efficacy in real-world circumstances versus ideal circumstances. We would plan to pilot in some institutions first and then expand as needed. We believe that this will require the support of many different disciplines to contribute the data that this model will be based upon. And we also believe that this, by reducing the resources needed, it will help people in a wide variety of socioeconomic backgrounds as well. Thank you.